coding and things regarding telemedicine in the last week. So thank you so much, Nancy, for taking your time to be here today. If anybody didn't hear me earlier, you can certainly use the chat or the Q&A during this presentation if you have questions. You might want to hold those to the end, as there is a lot of information, a lot of slides to get through. And if we can't get to those, we'll come up with some means of communication to answering those questions and getting that information out there. And Nancy will be providing the same webinar today at 3 o'clock Eastern time. So if you were going to join both of them, just know it's going to be the same session, which you're certainly welcome to hear this information again. So Nancy, we'll let you get started.
Okay, thank you very much. I appreciate the opportunity to speak to everybody and share with them the information that I've learned and researched extensively in the last week. If any of you knew anything about telemedicine coding up until last Monday, March 16th, what I'm going to tell you in this presentation is only pertaining to the new rules that we're allowed to operate under during the COVID-19 emergency. Health and Human Services released information last Tuesday, March 17th, that is effective for dates of service on or after March 6th, 2020. So don't get confused about what I'm saying if it conflicts with what you previously knew about telemedicine codes, because that information about telemedicine codes is outside of the realm of this emergency. So what I do to understand this clearly is take all that information that I used to apply, put it in a shoebox and put it on the desk, on the shelf, put it away for the duration of the COVID-19 emergency, and follow the new relaxed rules that HHS has waived, CMS has clarified, and we're operating at a different time right now. And this administration has directed HHS to try to help providers take care of their patients while keeping their patients at home. And to that end, I will go ahead and I will describe all of the rules that we're going to research under and live under today. So there's my bio and email and phone number if you have questions as well. And my business partner, Mike, has participated in this research. We're going to go over quite a bit of information in the next hour. And I know that the first time I did this presentation Thursday last week, it was hot off the press, and I had over 100 questions. They were being typed in before the webinar even started. So please hold your questions or jot them down on the side. I'm most likely to answer all of them in the new telemedicine code overview discussing the waivers under Section 1135 waiver request from CMS. We're going to really talk about mostly how you document and bill for the E&M codes when your patients are not coming into your office for these newly allowed remote visits, which is really important for your practice because the reimbursement for your E&M codes is significantly higher than the telemedicine virtual check-in type of codes. So I want to make sure that you're documenting it correctly and seeing those patients through the video and audio rather than having them leave the safety of their homes. We'll also talk about some telehealth modifiers and when they're waived and the diagnosis codings. We have a lot of detailed handouts for you. We'll provide you the slides. We'll provide you with an up-to-date frequently asked questions sheet. I have a sheet with the reimbursement amounts and a telemedicine grid. So with all that, you should be armed and ready to go ahead and do your services and go back last week and see if any of them actually qualified and capture that revenue as well. Generally, telemedicine is the practice of medicine using technology to deliver care at a distance. The physician's in one location using infrastructure in another location at a distant site. As long as the physician performs and documents the elements of history, exam, and medical decision-making now, or the time counseling, document them the same as you would as if you saw the person in your office and meet the conditions of a telemedicine visit, and then you can bill the E&M codes. Usually Medicare requires the GT modifier. As of last Tuesday, they said that they're not requiring any modifier because the place of service code 02 is going to tell them it was remote during this period of time. Then after these temporary measures go away, yes, Medicare does have the GT modifier. Most insurance companies accept the 95 modifier. There are a few other modifiers as well, but we don't need to worry about them during this time. Now you can use the E&M codes 99201 to 99205, 99211 to 99215. Consult codes, they can be reported with modifier QT or 95 depending on the payer. Again, Medicare doesn't require the payer right now. And we have embedded, as you'll notice, links to a lot of other references for you. What do the modifiers mean? Modifier 95 is synchronous telemedicine service rendered via a real-time interactive audio or video telecommunications system. So this is the long-term definition of the technology that's required for HIPAA-compliant telemedicine services. You may be using a business partner who has signed a HIPAA business associate agreement with your practice, perhaps a vendor that is working hand in hand with your practice management and EMR vendor. So that's for the long term, if you're meeting that criteria. But right now, as of last Tuesday, Secretary Azar has waived a lot of the telehealth requirements going back to services for March 6th. And we are seeing very quickly that other payers are sending bulletins and putting information on their provider portals that their policies are also relaxing and are likely changing, in accordance with CMS. But we cannot give you advice on this call for every individual commercial insurance carrier. Of course, you need to read their bulletins as well. One of the first restrictions that this waiver has dropped is the geographic restrictions. So patients no longer are restricted to being in rural locations. So now patients anywhere, regardless of where they live in the country, state, or county, are eligible for telehealth services because the goal is to keep everyone at home. The waiver also eliminates the site of service, or the originating site as it's called. Now it doesn't have to be in another physician's office originating the call, or another healthcare facility, such as a rural hospital or a health clinic. Now patients can make these audio and video visits with their providers right in the setting of their own home. The type of communication, as I just mentioned with the definition of the 95 modifier, is also being relaxed. So now that type of audio video communication platform is not going to be restricted to a HIPAA vendor, but now because of the emergency, you can use any non-public facing remote communication product. That includes smartphones. So smartphones have audio and video capabilities, and that's the big takeaway. You want to make sure that both the patient and the provider are on some kind of a device that has audio and video capabilities. Without video, then you can use the virtual check-in and telephone call CPTs that we'll discuss in upcoming slides. Real-time communication is something that is required. So the physician has to use interactive audio and video so that they're talking live, such as FaceTime. Under the Health and Human Services Notice, the OIG also came out with some guidance, and the OCR, the Office of Civil Rights, is the government body that oversees HIPAA privacy, and they have also relaxed their enforcement. But they did specifically say, however, things like Facebook Live, Twitch, TikTok, other similar video communications are public facing and they're not secure, so they should not be used in the provision of telehealth by covered healthcare providers. So Facebook Live, no. FaceTime, yes. The OCR is going to exercise their discretion. They're not going to be imposing penalties for non-compliance over the regulatory requirements, but they do expect you to make a good faith effort to protect the patient's privacy, and there is a link to the privacy notice on their website. During the COVID-19 national emergency, covered healthcare providers subject to HIPAA may communicate with their patients. You don't have to have the usual signatures on your forms for patient authorization, and that kind of thing will also increase access and cut through some of the red tape that we usually have to manage when we're remotely talking to our patients. Now, some practices might be in a larger environment when even their own internal security provisions will not allow a provider to have a virtual visit with a patient using their own private cell phone, even though it does have audio and video to meet the CMS requirements. You might want additional privacy protection. And if that's the case, then we do strongly recommend that you use some kind of HIPAA compliant vendor and enter into a HIPAA business associate agreement with them. But if you're not using any of these solutions right now, you still can go ahead and bill for the time being under the emergency measures. Who can provide these services is any qualified billing provider. There's really no change. If you can put a provider's name on a claim today, then you can do it with the virtual codes as well. So we're talking about all of the doctors, nurse practitioners, physician assistants, nurse midwives, certified nurse anesthetists, clinical psychologists, clinical social workers, dietitians, nutrition professionals. All of these folks are licensed healthcare professionals and credentialed with the payers, and you bill under their own name and number for their own services. Notice here that it does not say anybody in the support staff, whether it's clinical, such as the nurse or medical assistant or any other staff members. There are 101 CPT codes that are designated as eligible for telehealth payment, and we've put together a one-sheet PDF that you can request, and we'll send that out to you. It is all the CPT codes for the office and outpatient visits 99201 through 99215, as we mentioned earlier. The subsequent hospital and nursing home codes, as well as psychotherapy, behavioral health assessments, end-stage renal disease, to name a few. This is not a complete list. There are many others. I did note on the slide that preventative medicine visits are not covered for any age, because that did come up in previous calls, and I wanted to point that out ahead of time. Although the Medicare annual wellness visit, because that really is not including an objective physical exam, that is allowed and is on the list. Medicare telehealth services are generally billed as if the service had been furnished in person, as long as it is designated as such. And then the place of service code that I mentioned earlier, even though the provider might be in the office, the place of service is 02 to indicate that it was accomplished through this remote circumstance. So use the distance site 02 place of service for telehealth. The good news is that Medicare will pay the same amount for telehealth services as it would have if the person came into your office. So if you're billing a 99214, you know what your reimbursement is for that, rather than be limited to the telephone calls or the virtual check-in, which pays about $13. Now you will get paid for your usual reimbursement for those visits. So providers can work through their schedule, make all the calls to their patients with the audio and video, and then Medicare will use the facility payment rate when the services are furnished via telehealth. So that's one of the most important things here, is to realize that you can keep your reimbursement if you keep in touch with the patients using this new technology during this time. Now, operationally, how do you collect a copay when the patient doesn't come in for their visit? Usually the compliance folks, I'm one of them, will always say you cannot waive a copay. That's illegal, and it's always part of our compliance plans, right? But the HHS said that they are going to reduce or waive the responsibility for collecting copays at this time. They're providing flexibility on that because the patient's not in front of you to pay that copay. If you can't operationalize quickly a way to take a credit card remotely, then you might be forced to, bill the patient or collect at their next visit or what have you. This is not to say that you cannot charge the patient a copay or that you cannot collect a copay or cost sharing or deductible from those patients. It's just saying that if you don't collect it, you're not going to be in trouble at this time. Just another way the government is trying to make this simpler for all of us to get those patients cared for in their homes. Also, telemedicine has rules usually about having the patient being an established patient who's seen the provider in the last 3 years. That has been waived, and they will not be doing audits to make sure that the patient was an established patient at the time of their telemedicine visit. So if you're using the new codes, the 99201 to 99205, we'll get to the documentation requirements in a moment, but remember that you have to have 3 out of the 3 elements: history, exam, and medical decision-making, or time. So with those new patient visits, of course, you won't have the middle element of exam, so you're going to have to consider time if you're using the new patient range of codes. Even before the availability of this new waiver, CMS did have some changes last year for the virtual check-ins and the e-visits, and we'll be going over them as well. You can use all of these codes during this period of time if they're more applicable to the service and the documentation. G2012 is the virtual check-in, and this is by a physician or other qualified healthcare professional, meaning a billing provider, a licensed provider for E&M services that don't lead to a visit coming up in the next 24 hours or weren't in follow-up from a visit from the previous 7 days. Now, the national Medicare average reimbursement for this code is about $14.80. I put it here just to illustrate the difference in the reimbursement for these types of codes versus your regular E&M codes. And I did check with CMS and got a response from them this morning. The G2012 can be by telephone. It doesn't necessarily have to be by audio and video. This can be telephone only for the virtual check-ins. The virtual check-ins pay the professionals for a brief 5 to 10 minutes, where the Medicare telehealth is going to be treating the same as an in-person visit as long as you use the place of the E2 codes. So make your choice of the codes based on the documentation, and if it is going to be brief, or if it's going to meet the definition of these e-visits, the G2061, 62, and 63, that are going to be the qualified non-physician healthcare professionals. So depending on who is doing the visit, the virtual check-ins would be better for the physicians and advanced practitioners. And then the clinicians who are not billing as such, physical therapists, occupational therapists, speech and language pathologists, clinical psychologists, they can also use these codes. They're considered the non-physician healthcare professionals. So G2061 through G2062 can be used depending on the total time that is cumulative during a period of 7 days. The reimbursement isn't much here, but it does give those other professionals a chance to bill for their services as well during the time that they can't have inpatient or in-person services. Digital evaluation management is also another way you can report. The codes that begin with the 99 are accepted by commercial insurances. The G codes are usually accepted only by CMS, and this is another way to report those codes. This is a little snapshot. I'm sorry, it's a little bit light of what is included in those digital E&M services. So just a reminder, it is cumulative service time within a 7-day time frame needed to evaluate, assess, and manage the patient. Medicare has this snapshot on their website that shows you what the types of service are for Medicare telehealth visits, virtual check-ins, and e-visits, describing what the service is, what the CPT codes are that you can use. And you'll notice again that there are some CPT codes here on the bottom for the e-visits, 99421, 422, 423. I would use them for commercial payers, and then the G codes are generally accepted by Medicare for their claims. And there are some notes about provider relationship with the patient as well for these codes. So that's a pretty handy chart for you. There are physician telephone service codes as well, 99441 to 99443. So for those payers who don't accept the Medicare G code for the virtual check-in, you could try to use these codes for your other payers. Because these are time-based codes, for the last several slides I've been talking about time-based codes, your notes should always reflect a summary of the discussion and the total time spent, whether it's on 1 day of service or over a period of 7 days, depending on the code description and what the requirement is. This range of codes, 99441, is for the E&M service by a physician or other qualified healthcare professional over the telephone. And the next range of codes is by a non-physician. So this could be by the nurse, 98966 through 98968. And again, because they're time-based codes, summarize the discussion and document the time spent. Now, when you're going to be using the codes to substitute for an inpatient evaluation and management service and the providers responding to an appointment, these are always initiated by the patient, by the way, and document that as such in the beginning of the note, and also document in the beginning of the note that they were remotely accomplished using audio and video. And then you need to have either a SOAP note or the time documented to support the level of service, because otherwise, without a SOAP note, how would you know if you're going to bill a 99212, 99213, 99214? So this should not be put into your EMR section under telephone encounters or phone notes. Open an encounter and document it as a full SOAP note for an office visit to satisfy all the documentation requirements for an evaluation management service, such as your SOAP note format. Having this template filled in will support the level of service that you're billing. And of course, the middle one here, the objective for the level of exam, is going to be, very scarce unless you have the opportunity to make a comment on the patient's general appearance, or if the patient has some simple tools to take their blood pressure or pulse ox at home, or they can give you their height and weight. Or usually it's, things that would be obvious to the provider if the patient is pale or things like that. But we're really going to have to count on the other two levels of history and medical decision-making to calculate that level of service by documenting the history of presenting illness. So the patient is still going to be telling the provider either how they're doing since the last time they were seen, or if they have a new onset of a new complaint, how long that complaint has been going on, and what the timing is, how frequently it happens, is a pattern, how severe, or what the quality is of their symptoms, and so forth. A brief 1 to 3 elements of HPI will give you a 99212 or 99213. An extended HPI with 4 of the elements in the first bullet will support a 99214 or 99215. The chief complaint and history of presenting illness would then lead the provider to ask questions to create a review of systems. This should not be a 14-point checklist with all of this negative unless it's appropriate to ask that many questions. Usually the HPI supports the extent of the review of systems. For example, if a patient has a headache and they say when they have the headache, it's really bad to the point where it causes nausea, then you have GI system reviewed. There are 4 levels of review of systems. So 99212 doesn't need any. 99213 needs 1 system. 99214 needs a second system. So again, the headache and nausea is on its way to a detailed history, and comprehensive is 10 systems, or some systems with the others statement of all of this negative, as long as that was truly discussed. And you still have to document some past family and social history as clinically appropriate. Usually the patient's prior illnesses, medications might be discussed, allergies if the provider is going to call in some medication, family history. These are risk factors, not exposure in the house right now. Exposure to others who are ill is social history, as well as any other lifestyle factors the provider has to take into effect. So we were talking about documenting a regular history, and then you've got the HPI, ROS, past and social history, circled whichever level it comes down to, and then to select the level, you draw a line across the row that has the least documentation. So you'd have to have everything in the expanded problem focused met for 99213 and the detailed met for 99214, for example. The objective should be documented as much as possible if the provider can observe anything through that video or glean some information. The patient might hold their hand up to the camera and pinch their fingers to see if there's capillary refills, and there's some things that can be done, and certainly height and weight and anything else that can be confirmed can be counted. But we'd go right then into the assessment and plan, listing the number of diagnoses, any data, if the provider had information from recent tests the patient had, or decided to order tests. That complexity would give the data points here, as well as the plan of care. The number of diagnoses is going to give you points, as well as the number of points that you get for the categories of data. And the table of risk look like this. There hasn't been any change in this recently, but there will be in 2021. Once we get through this crisis, we're going to have new training in the fall to talk about the 2021 changes. But today, it hasn't changed at all. It's the box A in the Marshfield Clinic guidelines that show you the number of points for each problem, whether they're new or established. The number of points for labs, imaging, or tests in the medicine section like EKGs, EMGs, neurology testing, and so forth. Discussion of the test results with a performing physician, or deciding to get history from someone else or records from somewhere else, or summarizing those, as well as independently visualizing images. All of this is going to add up to the complexity of medical decision making. The presenting problems will also support the level that you're billing for this non-face-to-face visit using an E&M code. So minimal is going to be minor problems, 99212. Low is going to be 2 or more self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness. Those are low. Things like UTIs, rhinitis, sore throats, sinus infections, minor injuries. Those are all considered low risk for 99213. Moderate risk would be 2 or more stable chronic illnesses. This might be typical for patients that have this non-face-to-face E&M service to follow up for their medication refills, if they have diabetes and heart disease and things of that nature. Or if they have 1 chronic illness that's worsening, they have some side effects of treatment. Or if they have an undiagnosed new problem with uncertain prognosis, meaning there's going to be orders given for workup to begin. Those are all in the moderate risk, as well as acute illnesses with systemic symptoms, pneumonia, acute complicated injuries. All of the moderate risk would support in 99214. And high risk is going to be 1 or more chronic illnesses with severe exacerbation, progression, side effects of treatment, things that pose a threat to life or bodily function, organ failure, abrupt neurologic changes, strokes, seizures, TIAs. Of course, the high-risk things would probably end up in the patient being sent to the emergency room, but the encounter that the provider is doing to ascertain the extent of the problem could still be billed as a high-risk visit, even if it was not face-to-face. The management options also can be selected, and you don't have to have both of these columns. The highest level of risk in any of these columns will support the level of risk for your calculation. So the low risk is rest, hydration, dressings. Minimal risk is rest, hydration, dressings. Low risk is over-the-counter medications. Moderate risk is prescription drug management, and high risk is, to the hospital. The way that we calculate the complexity of medical decision making is to blend all 3 of those elements together and select your level of MDM based on the level that is 2 of 3 elements are met or exceeded. So low complexity is 99213, moderate complexity 99214, high complexity 99215. Usually we see the statement greater than half of this face-to-face encounter was spent in counseling and coordination of care. Time is going to be really important with the lack of a physical exam for these visits. So I would recommend that not only you write that it was a remote encounter at the top of the note, but also make a habit of putting the total time of the length of the encounter and summarize the discussion here as well. For coding purposes, face-to-face time in the office is usually only the time the physician spends face-to-face with the patient or family, but now face-to-face time is going to be FaceTime using the audio and video connections to the patients in their home. Interestingly enough, this change is going to be in line with the way we think about selecting the level of code based on time in the future going into next year. This is a snapshot of how you would calculate the level of service by either using history exam and medical decision making or time. And I have done some auditing for CMS in previous years, and I want to remind you that it's not one or the other. You have a choice. I'm not going to tell you you have to have a SOAP note and calculate the level of service that way, or you have to have time and calculate the service based on time. You have the option of calculating based on whatever is most advantageous to the provider by reviewing the documentation. So this is your choice. For the new patients, you are required to have all three of the three components of history exam and medical decision making in your exams, or they won't exceed problem focused. So for the new patients, I would encourage you to consider time. But for the established patients, if you have a detailed history and moderate medical decision making, and it took 20 minutes, not 25, that still will support a 99214. The telehealth modifiers right now, CMS is not requiring additional or different modifiers associated with the telehealth services under the waivers, but I will go over them anyway because I don't know what the private payers are telling you. In fact, on the next slide, I have a little snapshot of something from Blue Cross Blue Shield of Massachusetts, and I've seen other insurance companies requesting the modifier as well. So you have the GT modifier, GQ, G0, and 95. The 95 is listed here, synchronous telemedicine service rendered via a real-time interactive audio and video telecommunications system. So today we can look at, FaceTime or Skype or Zoom meeting, as well as the traditional telehealth platforms. Under the CMS waiver, CMS did say that the state Medicaid programs have broad flexibility to cover the telehealth services accordingly through the Medicaid programs. They don't need any federal approval to modify their payment policies. A state plan amendment would be necessary to accommodate any revisions to payment methodologies to account for the telehealth costs. The best thing to do with state Medicaid, with all your contracted local payers and commercial payers, is to keep an eye out for their provider bulletins. I know many of them have been coming out, as early as last Wednesday, or check their provider portals to see if there's any information there as well, because what I'm telling you isn't necessarily going to guarantee payment. It's going to tell you what you're allowed to do per CMS, and we can hope that most of the other payers are going to follow suit. So we know we can use the E&M codes. We're going to use the place of service too, and you're going to need a diagnosis code that supports the reason for the encounter. If patients are going to have that follow-up via FaceTime to go over their chronic conditions, get their last lab work, and refill their prescriptions, that's pretty straightforward because you know what the diagnoses are for those chronic conditions the patient carries. For patients who have new onset of problems and you have symptoms that weren't definitively diagnosed, you can report the symptoms, the cough and fever and nausea type of codes. Usually they begin with the letter R, and those will support medical necessity for an encounter and get your claim paid as well. Diagnosis coding is allowed for any issue, any health issue, any reason. So it's really important to remember that this provision is not just to allow patients their access if they suspect they have coronavirus. This is for everything in order to stress the importance of social distancing and keep the patients at home. So if a patient could use this, for a visit for their doctor to receive a prescription refill, all of these things will be considered reasonable and necessary, just as if the patient came into your office to have that visit instead. So just to recap here, the key takeaways is this is for all dates of service on or after March 6, 2020, and it will go on for the duration of the COVID-19 public health emergency. I hope that it ends sooner rather than later, but we will certainly give updates as these provisions are taken away. These visits are considered the same as in-person visits, and they are paid at the same rate as a regular inpatient visit. So if your providers are on the phone with patients, make sure that there's a note written, find out if it was a patient-initiated call, find out if the elements of an evaluation management service were documented and provided, and use the E&M codes instead of just the virtual check-in or telephone codes, and you won't lose as much reimbursement through all those visit cancellations to your clinic. And that will certainly help during this time. Starting March 6th and for the duration of COVID-19 public health emergency, Medicare will make payments for all professional services in all areas of the country, no geographic restrictions, and in all settings. So home or anywhere the patient is allowed at this time. Again, social distancing. It doesn't need to be in a physician's office or skilled nursing facility where the patient is located to communicate with your doctor. It can be in their homes or any place else at all. The Medicare coinsurance and deductible would generally apply to these services. However, you do have flexibility for reducing or waiving the cost sharing for telehealth. It's a practice decision that you can make. You can certainly bill the patients or collect it at a future visit if you don't want to waive it. The rule is not saying that you have to waive it, but if you do waive it, there will not be any problem with that under the OIG compliance regulations. Also, with the new patient versus established patient exception, under the 1135 waiver, HHS will not be conducting audits to look and see if you actually had seen that patient in your office within the previous 3 years. So that is waived as well. And at this point, I'm going to stop and open it up to questions because I do have in this presentation another 10 slides or so that you can reference after this period of time goes away and we get back to normal. This is only a temporary situation that we're in, and you will understand better how to use telehealth. And perhaps if you have a good experience with your patients and with your providers providing telehealth, maybe this will get everybody on board, and we as a country will provide more remote care to patients than we ever did before. So with that, I will open it up to questions.
Okay, can you hear me?
I can.
Okay, we have several questions. For a virtual check-in, could the RN or MA perform those services?
No.
Okay.
The virtual check-in is by a physician or other qualified healthcare professional, and an MA is not a qualified healthcare professional.
Okay.
A nurse is not.
And for a nurse is not. Okay.
No.
Okay. For phone-only visits, can they still use the regular office E&M codes?
No. The office E&M codes can only be reported when both the patient and the provider have the availability of audio and video. So that would be a smartphone using FaceTime or something similar, or a computer using Skype or Zoom, where they have both audio and video on both ends, the patient and the provider. If it's telephone only, you can use the telephone call codes 99441 through 99443 for a provider. The telephone calls 98966 through 98968 for a non-physician. That would be physical therapists, occupational therapists, speech pathologists, clinical psychologists, or for Medicare beneficiaries, G0212, which again is limited to the physician or other qualified healthcare professionals, which means a licensed billing provider, not the staff.
Okay. Can the provider provide these services from their home?
There are no restrictions for the location of the provider at this time.
Okay. And if they're billing from their home location, is there
Place of service is,
anything?
the place of service is O2.
In the location?
Yes.
Is their home?
Yes. There is no location for the physician's home per se. The location for all of these telehealth services will be 02 to indicate that it was done via technology, the connection for telehealth, rather than in person.
Okay. Can telemedicine be used for patients in assisted living facilities?
Yes, there are 101 covered CPT codes, and we'll provide a list to you. And the nursing facility care subsequent codes 99307 through 99310 are on this list.
Okay. Does technology time count towards the total visit time?
The total time would be the time that the provider spends face-to-face with the patient. I don't know if technology time means establishing the connection in the phone call, but if it's administrative without professional services being rendered, no. It would be the provider's time face-to-face with the patient.
Okay. Does the HIPAA waiver for using and billing for non-HIPAA compliant televisit software like FaceTime, does that apply to other payers as well? We're getting mixed messages from different payers.
Different payers will have their own payment policies. And if you're a contracted provider with a certain payer, you do have to abide by their policies. But I would hope that we'd see more and more becoming lenient with this because of the emergency, and not expecting a patient to come into the office to sign a waiver or an authorization form. The point is to keep them at home.
Okay. Is time used to send a letter to the PCP included in the billable time? It's not face-to-face time.
No.
Right, which I just, okay. Are audiologists considered non-physician providers that can have telephone or telehealth visits? And what place of service code would be used?
There are no codes for audiology on the list of 101 covered CPT codes, so no audiology.
Okay. I've received notices from my billing company that you can only bill up to a 99213.
I have heard limits on the level of service per certain payers, so abide by the payer notifications that you receive. But Medicare does not have a limit on the level of service. All the E&M CPT codes from 99201 through 99205, 99211 through 99215 are on the CMS approved CPT list for telehealth. But I do know that other payers are being more restrictive.
Okay. Somebody said we are a house call practice. What codes do we use?
A house call practice?
Yeah.
Do they go to
I'm
the
hoping
patient?
you know.
Well, the purpose of this this waiver is to keep patients in their home. So if these practitioners are truly going to the patient's home, then they could bill as usual, no change in their business. If they're using telehealth to visit patients in their phone, then these changes would apply to them just as we've described, as long as they are, the type of provider that is allowed, meaning physician, nurse practitioners, PAs, and the like.
Okay. And many people are asking if this session will be available, the slides will be available after this call, and we said yes, we will share those out with everybody.
Yes, and it's really important that that they get the updated frequently asked question list, because every time I ask a question to my colleagues in Washington and they get a response from CMS, they're rapidly giving that information to me, so that FAQ sheet has been a very dynamic, up to the minute document that I'll be happy to share.
That'd be great. Is the patient-initiated call required for telemedicine?
Yes, that's a great point. I'm glad that you brought it up again so we could reiterate that. All of these must be patient-initiated.
Somebody said, thank you for the great presentation. My question is about the physical therapy billing via telehealth. Can you please clarify? Anything
There
special
are,
for physical therapy?
sure. The telephone codes 98966, 98967, 98968 are for physical therapists, occupational therapists, telephone assessment and management services provided by one of those professionals I just mentioned, not originating from a related assessment and management service provided within the previous 7 days, nor leading to an assessment and management service within the next 24 hours, 5 to 10 minutes, 11 to 20 minutes, or 21 to 30 minutes, looking at the CPT code descriptions. So that can be for, the physical therapy and occupational therapy where they have telephone only visits. That would be the code range that would be appropriate for them.
Great. The next question is, our practice is a long-term care / post-acute care. For our typical RCFE visits, which would be 99335 or 99336, would we bill place of service 2 with CPT code 99335 still, or a G code?
The codes you just mentioned are not on the CPT code list for approved services. I can send you the PDF of that so you can take a look at all the codes that are allowed. There's subsequent inpatient hospital care and subsequent nursing facility care codes, but no other site of service for rehab.
Okay, yeah, many people are asking for that code list, so we'll definitely share that out. That'd be great. How about a physician's assistant? I guess they're asking if that.
Yeah, and the doctors and the nurse practitioners and the physician assistants are all considered the same for documentation, coding, and billing purposes in this situation.
Okay, somebody actually asked, and I can answer this question, why do we need to buy an add-on module by doctor first? We're not requiring anybody do that. As Nancy alluded to in her presentation, there are many options, and you can choose what's best for your practice. Care Tracker, the Amazing Chart suite of products, if you're using Care Tracker or Amazing Charts or Clinics or Pulse, any of our products, you can sign up with doctor first, and we'll develop integration over time. So that's our preferred vendor. If you're using a different telehealth vendor, that's fine. That works for you. Or using FaceTime or whatnot, that's specific to your practice, but we're offering the connection with doctor first as our long-term solution. So you're not required to buy, but you certainly can. Can the PA do check-ins? I guess that goes along.
The virtual check-ins can be done by the PAs. Yes, absolutely.
Okay. Sorry for getting some repeat questions. There's a long list that I haven't been able to look through yet, as they're all coming in right now.
Yeah.
Is there a specific set of ICD-10 codes which justify these televisits? You mentioned the symptoms. Our codes will work.
Yeah, the ICD-10 codes can be supporting any reason that the patient has an encounter with the provider. In the absence of a definitive diagnosis, use the diagnoses for signs and symptoms, but any diagnosis will work.
Okay. So somebody asked, and again, I can answer this question, what are the advantages of a dedicated telehealth system versus just a smartphone, Skype, and is it a HIPAA issue? So again, as Nancy said, they've waived a lot of the HIPAA requirements and are lenient with their audit policies and things like that. So using something like FaceTime it could be appropriate if you chose to do that. Not using things like Messenger through Facebook or something like that. That would not be appropriate. There are many telehealth vendors out there that are offering HIPAA compliant solutions, such as Backline through Dr. First that we're offering. So really you'll have to make a business decision based on your practice and what requirements you would like to meet, but they're asking that everybody makes a good faith effort to keep their patient's information secure. So your practice might decide that they want to use a HIPAA compliant solution, or they might want to use one of the other options. That's a decision based on your practice.
If I could add to that, Jess, something that's been worrying me is that a lot of the providers, if they're going to be using their own iPhone for audio and video, they're going to need some way to block their number as they call patients, so they don't disclose their own personal cell phone number to all of their patient population, as well as other cell phone use policies by different organizations. They're all work cell phones. So it is good to use the safer method of communication when it's at all possible.
Rhode Island, the governor said that all televisits would be reimbursed at the full office E&M codes. Would that supersede Medicare? It definitely applies for commercial.
Medicare is federal. Yeah, Medicare is federal, and Medicare is reimbursing at the facility fee rate. And I don't think that a state mandate would override that.
Okay. Do you have a simple fee ticket for us to use when using telemedicine? I think each solution has their own workflows in terms of what tickets you should be using. So I would check with your individual software what they're recommending for workflows. Is Medicare covering 99441 through 99443 telephone visits?
No, they want you to use the virtual check-in. Which is the G2012.
All right. When do you use the 95 modifier?
After this emergency is over with, then you could check with different payers on their requirements for modifiers. They're payer specific, but as of March 6th, claims that go to CMS, to Medicare, do not require any modifier at all.
Great. What is the difference between telephone call versus virtual check-in?
Simply, the virtual check-in is unique to the G code mandated by CMS, and the telephone call is very much the same, but is reported with the G code. And usually when Medicare allows coverage for something that is not usually covered by the traditional CPT codes, then you use the G codes. So in short, G codes for Medicare, 99441 for everybody else.
Okay. Some of our providers are trying to use video with patients. They're finding out that the patient, mostly the geriatric population, can only use the audio. So what should they bill for that?
They can use the virtual telephone, the virtual check-ins G2012 for Medicare patients, and patients with other insurance, the 99441 for the telephone evaluation management service by a physician.
Okay. There's a question here which I can answer. How's the place of service set in Care Tracker? So you'd use your location, and then you'd add the telehealth place of service under the location maintenance in admin. So you just add that telehealth O2 place of service to your existing locations. It's already there. It's already available for you. You can just go ahead and add it. If you have a question, you can send it in the chat. We'll get through as many as we can in the next couple of minutes. And again, the slides will be available, so if you have some of these questions, they might be able to re-review the slides and find out the answers to your questions. Is there any requirement to store video recording?
No, not at this time. Under the waiver, it's not necessary.
Is it considered patient-initiated if the office calls to offer the patient with a previously scheduled office visit the option to do a telehealth visit?
No, CMS actually is encouraging providers to make their patients aware of the availability of the remote visits. So that's not a problem. But then the patient would have to say, yes, please, I want to talk to the doctor on Tuesday at 10, have him call me. And then that would justify the patient request.
Mm-hmm. Okay. That just answered a couple questions, actually.
Okay.
So let me just read this one. It's a little bit longer. Governor Baker, in his order on 3/10/20, indicated all carriers shall not impose any specific requirements on the technologies used to deliver telehealth services, including any limitation on audio only or live video technologies. What does this mean?
We see through the regulations issued by CMS that there are ways to bill for either circumstance. There are codes for audio and video, and there are codes for audio only. So those are not restrictions at all, and they seem to comply with the governor's order. I don't think that the governor meant to say that you can bill a 99214 for a telephone call. I think we understand the purview of all of this.
And we have people asking just to confirm all modifiers are waived during the COVID-19 emergency.
All telehealth modifiers are waived. Mm-hmm. Yes.
Great. There's questions asking to clarify the location versus place of service if they're at their home. So we had heard that you needed to register your home address on the PICOS website and use the provider's home address if they were home with the place of service too. Can you confirm that or no?
I have not heard that at all, and that does not go along with what was issued by HHS and the waivers issued on March 17th for services going back to March 6th. If that's something that is in the broader scope outside of the COVID-19 emergency for enrollment in telemedicine, that sounds reasonable, but it would not apply at this time.
Okay. Where do care managers fall in the scope of practice of telemedicine? Does their credentials qualify for services? So care managers.
Care managers would most likely be listed as the non-physician healthcare professionals, and not use physician codes.
Do providers need to submit the 1135 waivers to CMS for telemed billing?
No.
Can specialists do their normal E&M follow-up visits and inform the patient that they're now offering telehealth without the patient initiating the visit? Yeah, we already addressed that, sorry.
That's okay.
So we have several questions about like FaceTime not being HIPAA compliant. So I know a lot of people might have joined late and missed that slide. If you just want to maybe address that again.
Sure. The Office of Civil Rights, which oversees HIPAA privacy and security, has said that they will not be enforcing HIPAA regulations regarding using patient-facing technology at this time. So smartphones, for example, or Skype or Zoom are allowed as long as they are quote unquote non-public facing. It's only between the two parties. Other things that could be public facing, such as Facebook Live or TikTok or Switch or I don't know what it is. I'm too old to know all those acronyms for what the kids are using, but no live streaming for sure with Switch and those kind of things, or Snapchat or anything. But FaceTime is between two parties, and FaceTime on a smartphone or Skype or Zoom is definitely allowed. And on my FAQ sheet, there are links to the OCR, the HHS, and the CMS sources for what I'm telling you.
Okay. We actually received 112 questions, so we do not have time to go through all of them. We're already past the hour.
Well, I promise that when we pass up the FAQ sheet that I put together after my call that went till 11 o'clock Thursday night with over 700 doctors in 20 different states. I think they thought of every question that you might have on this call. I'm going to send that along right now, and you can distribute it. And between the slides and the FAQ sheet and the CPT code list, if there's anything that we have not addressed, please email me and I'll be happy to answer those questions individually by email.
That was wonderful. Thank you so much. We will definitely share out. We will have the session again at 3 o'clock today if you want to take the session again, and more information to come. And thank you so much for your time. Really appreciate it.
Thanks, everyone.
Thank you. Bye-bye.